everybody to the next edition of the MGH Research Institute webinar series, interviews with interesting investigators. I'm Jonathan Rosand. I'm the managing co-director of the McCance Center for Brain Health here at Mass General, along with Rudy Tanzi, distinguished neuroscientist, geneticist, and Greg Friccione, distinguished psychiatrist. I founded the McCance Center with the goal of developing and deploying simple approaches to effective primary prevention of brain disease in routine practice. Our work is broadly multidisciplinary. It spans everything from lab discovery to data science to clinical trials to implementation science. And of course, one has to get into health economics and health policy in order to be successful. So we've had a wonderful time building and expanding a team that brings together passionate people who are devoted to preventing brain disease. And I'm thrilled to today introduce Alessandro Biffi, one of our distinguished faculty, a dear friend who has been really at the forefront of developing a vision for preventing age-related brain disease through his own work. Alessandro received his MD at the University of Milan, Bicocca, and then joined Mass General first as a research fellow, then as a resident, and now as faculty. And he'll tell us a little bit more about his background. And so I think without further ado, Dr. Biffi, maybe you could tell us a little bit about what led to your landing here at Mass General and why you've chosen to remain here.
Yeah, absolutely. Thank you. Thank you, Jonathan. It's really a pleasure to be here talking about brain health. The path towards sort of like being interested in brain health started fairly early in life with experiencing multiple members of my extended family battling loss of brain health through a variety of different neurological and psychiatric conditions. So I think that was a formative experience and the desire to better understand and better care for those people in my family and beyond was really one of the things that drove me to medicine and then ultimately to brain medicine, to brain health in many ways. Most things in life, I think, are fortuitous, are based on a combination of luck and perseverance. So I was planning to be at Mass General for 6 months back in 2008 to get a sense of how sort of like research could enmesh more closely with clinical practice in a way that's maybe not as common in the neck of the woods I trained originally in northern Italy. And I was fascinated by what we do here, by how you can be in the clinic, talk to a person, bringing you an interesting problem, not know the answer, but mull it over and go back to your research and try to find a question and take it back to that person and to others suffering from the same condition. So it was something unique. It's something I'd never seen in action before, and to this day, I don't think anyone does it better than we do, though that's maybe immodest. And it's what's kept me so fascinated with brain health since. It's really being both a doctor and a researcher, someone who asks questions and then answers them on behalf of their patient.
And you've pursued training sort of at the border of neurology and psychiatry. Maybe you could talk a little bit about that and then how that's informed the way you built your research group and your research vision.
Sure thing. I come from a tradition that, at least for me, feels very European and old world, of a clear division historically and practically between disorders of the brain that are neurological, that are more about electrical connections and sort of like building blocks in the brain, and psychiatric disorders. There's more disorders of the mind, or sometimes even of the soul, if you will. And I think that part of the journey that I undertook was an understanding that it's a very it's not really a barrier between the two disciplines. And if it is a barrier at all, it's very permeable. And really what I became interested in is the intersection between neurology and psychiatry, a field usually referred to as behavioral neurology and neuropsychiatry. So what are the factors that control the psychiatric manifestation of neurological disorders, and what neurological factors are key in the manifestation of psychiatric disorders? And that's what I've taken to my clinic, where I help in particular survivors of stroke who have both neurological and psychiatric disorders. But also I took it to my research, where I decided that the distinction is somewhat artificial, and that we focus on brain health in its totality. And I think we've done some interesting work showing that we better understand the life experience of our patients when we kind of tear down some of the barriers that compartmentalize disorders and conditions and problems. And we really talk about what people are experiencing as a whole.
So maybe you could give us a sense of what is sort of the routine experience of the folks in your lab. What kinds of patients are they studying, and what kinds of data, and what?
Yeah, absolutely.
Before you answer, I just want to remind you and the group how broad your background has been. You really were at the forefront of genomics for a while. You've done epidemiology, you've done, clinical imaging research, but how have you put it all together, and what's the experience then of working in your lab?
And for full disclosure for the group, I'm now proficient at essentially nothing, but somewhat competent in many different things. But that's really what I'm fascinated by, is what we learn from our patients when we use as many tools as possible to capture the disease things that are happening to them. And so the patients that we work with primarily are patients that have vascular brain disorders. That was our starting point in the journey to brain health, whether it be a stroke, like a permanent brain injury due to lack of blood flow or bleeding in the brain, or whether it's vascular dementia, which is like long-term accumulation of damage that causes cognitive problems. And as you mentioned, we've become proficient in a lot of different tools. And so we do ask our patient to participate in brain scans, CT scans, PET scans, to sit for neuropsychological tests, to provide us with biomarker data and DNA data, and to give us an opportunity to look at their medical records as well as their information to create clinical profile. And then the goal what people do in the lab is really taking all these different dimensions of data, which are patient experiences and our patient, they're really enmeshed in the reality of what they experience on a day-to-day basis, and not run away with individual parts of the picture, but really try to bring it all together. What do we learn when we mesh all of this data together, which is its own challenge from a computer and statistics standpoint. It requires its own tool, but most importantly, it requires its own mindset. It requires the desire to be, as I said, maybe not the world expert in anything, but really comfortable and conversant in a lot of these different things. And to be fair, to have great friends and collaborators who are world expert in these specific things, including Jonathan, who's one of the leaders in genomics, to turn to for help. But I think what we do.
One of the things that I think you have taught me, and one of the major observations to emerge from your group is how frequently this deterioration in brain health, as you call it, develops in people who've had, even a small stroke or even no stroke, but have, problems with their blood vessels in the brain. Maybe you could talk a little bit about the patient group you see and what you've learned about not just they're having a stroke in the future, but other aspects. Right?
Yeah, as you mentioned, we see a variety of patients, and I think sometimes it's tempting to put them in a spectrum of brain disease severity. And sort of like at the end of the very sick patient, we have survivors of stroke. Some of the strokes are big, large, very disabling, some of them relatively minor. And yet we have shown that the vast majority of them, unfortunately, are at very high risk for loss of brain health, for more strokes, for cognitive decline, for walking problems and falls and seizures and impaired mood and impaired emotional state and all sorts of different conditions. But as we move towards the less sick end of the spectrum, the people that have not had a stroke, or at least they're not aware of it, but maybe we see it on their brain scans, I think the theme continues to ring true, is that there is almost like an iceberg type of situation where when we look at our communities, we see a peak of patients that have developed severe brain disease and are at risk. But there's a large submerged population that is at very, very high risk for brain health, and that we don't capture in our clinics, in our hospitals, in our education program, in our communication efforts. And they're always, almost every day, one could say, teetering on the verge of losing brain health dramatically. And we don't have great tools to identify them, to help them, to reach out to them, to tell them what's going to happen, and to what are the next best step. And so that's what really has brought me to work closely with all the members of Team McCance, is really the need to not put out the fires after the fact, which certainly is needed and it's important. But there's a whole submerged aspect of a ticking time bomb in terms of brain health and loss of brain health that is staggering. And I don't know that people, that the public always appreciates that.
So one of the really inspiring aspects of the way you work is the broad diversity of disciplines you attract in your group and backgrounds. Maybe you could talk a little bit about what makes your group tick, if you could pick a few key characteristics that you think.
Yeah, absolutely. And it is true. And I do think it's a peculiar characteristic that maybe other groups do as well. But we do have a variety of different sort of like figures in the group. We have medical doctors in neurology with different specializations. We have physicians, MDs in psychiatrists. We have psychologists with different paths in training. We have sort of like data analysts and data scientists. We have experts in sort of like genomics, and we have experts in sort of like more of the qualitative aspect of science. We have experts in healthcare delivery. So it is important to build that shared culture and understand what makes people tick. I really hope, and I certainly think that that's the case talking to our team members, is that what makes us tick is really that taking it back to the patients. That we're not here solving some very abstract, very sort of like ivory tower problem. Mm-hmm. To figure out answers to very practical problems, like which medication we should use if you have a stroke and now you have depression and it's responding to treatment, or what is the best way to predict who's going to have another stroke. So I think what makes us tick is the fact that no matter how complicated the science we do is, we're really trying to answer questions that are super relevant to caring for our patients in the clinic and in the hospital.
I should have said earlier, for those of you who would like to ask questions of Alessandro, please put your questions in the Q&A, and I'll try and get to as many as possible over the course of let's say the next 15 minutes of the interview. Alessandro, I think it's also helpful for you to describe your experience with our own SRTP program, to be redundant. And maybe you could talk a little bit about the program and how it's really been an energy source.
It's been a catalyzer of so much enthusiasm. So many, I'm sure in the audience, know about the summer trainee research program, STRP, with the McCance Center for Diversity and Inclusion. It's a wonderful program that brings trainees at very staggeringly different levels of training, from high school to medical school, to MGH, to one of the research labs participating in the program, to learn how to do science, to learn what the mechanisms and the sinews of science are and how science is done, and do their own projects and see and get a jump start. And it's a program that very effectively targets groups that are underrepresented in medical academic medicine. We've been with the program, I want to say, for 7 or 8 or 9 years. I know it's been a wonderful experience, and I'm very pleased to say that these trainees ask the very basic questions that I think once again help us keep a stick. Yes, but why are we doing this? Who are we trying to help? And to have the answers to those questions ready. We're doing this because we don't know how to help these patients, and these patients have this problem when they go home and they need to decide what to do to take care of their brain health. It's been really keeping us tethered, I think, to that real important mission of helping the lives of helping preserve brain health, helping the lives of those that have lost brain health or are at risk of losing brain health. It's a terrific program, and I'm proud to say that many of the graduates of the program have joined the group later on in their career. They're good friends. Excuse me. They're good friends, and we stay in touch regularly. But most importantly, I think it's been an opportunity for the group to really be exposed to the great enthusiasm and the bright-eyed desire to use research to make a better tomorrow for our patients, which is what got me into this business to begin with. So it's good to keep that flame alive, and these trainees are really the kindling that keeps that flame alive year after year.
We're getting a number of questions about who are these people who are at higher risk for poor brain health outcomes. What are the causes? Maybe you could help folks understand, the context and of vascular disease that you're really honing in on. And
yeah, I mean, realistically speaking, they're basically, when we talk about brain health, we talk about a variety of different pathways that lead, ultimately all converge on brain damage. And there are four along different pathways, whether it is degenerative brain diseases, inflammatory brain diseases, or vascular brain diseases. Different populations are at risk. We certainly can pick out a few sort of like leading themes. For example, aging. The group I lead is called Aging and Brain Health Research for a reason. A staggering amount of brain health disorders are disorders of aging, not of normal aging, but rather of abnormal aging. And so as our population ages dramatically, a lot of these people move into the at-risk category. People that have had exposures to certain biological or social factors in their life, especially in the middle of their life, are at high risk. People that have experienced uncontrolled hypertension or uncontrolled diabetes or other of the conventional risk factor. But as we're learning more and more, people who have experienced poverty and sort of like discrimination and poor access to healthcare, poor air quality, are all independently at very high risk. So once again, that speaks back to that need to enmesh all this together in a single framework to understand the determinants of brain health.
We have one question. Sorry, I want to make sure.
No, go ahead.
One question that sort of is the next step. How are we, or and particularly your team, taking research findings to the bedside? And maybe you could talk about some of the blood pressure findings as an example and how it led to the brain.
Yeah. I mean, there's a variety of different mechanisms. Some of them are more sort of like abstract and just, we publish the results that we generate, and we champion at the hospital level, at the local level, at the national, international level, the adoption of some of the findings we had. For example, in the management of hemorrhagic stroke, as Jonathan was mentioned, in the past 5 to 10 years, we've made a number of breakthrough discoveries on the importance of aggressive blood pressure treatment and how important it is to lower it. And that has played a central role in the new hemorrhagic stroke management guidelines that were published a few weeks ago. So we certainly act at the institutional level and at the communication level. We also act at the program level. So because of the importance of blood pressure, we have created a platform to provide our patients with blood pressure monitoring, both clinically and as well as in upcoming research studies. We collaborate with other centers that do the same and try to implement at the bedside our findings. And then I personally do it myself as an individual clinician. I take the lessons that we've learned and champion their application at the bedside for my patient. I counsel peers about sort of like doing the same when they turn to me in an informal fashion. We do a healthy amount of lectures for doctors and nurse practitioners. And
we have a couple of other questions that are, I think, related to this. Maybe could you talk about the brain care score and how that's the sort of the patient-centered tool that was driven in many ways by some of your research findings. And then the next question will be about social determinants of health, which obviously is a big theme. So maybe if you could briefly address both of those. Right.
So the McCance is actually one of the really, I think, breakthrough application that McCance and really Jonathan's team as pioneered is the development of a McCance brain care score, which is a fairly easy to calculate at the bedside score that takes into account biological, social, and emotional factors that are modifiable. So it's a really a blueprint for action, and returns relatively straightforwardly a number that is an identifier of the current success the individual patient is experiencing in taking care of their brain. And Jonathan has piloted its application in a variety of different patient populations. I myself am really moving forward to apply it in a widespread fashion to stroke survivors. And I think it's a good first step, or first 2 or 3 steps, to be honest, because it's very flexible in quantifying brain health. Like, what exactly are we talking about? These are the factors that influence brain health that we can modify. And I guess that also takes us to social determinants of health, which are also modifiable risk factors. I think earlier in my career, I have been mostly investigating some of the biological determinants of brain health, whether it be genomics or environmental exposures or previous sort of like medical life experiences. But I've really had the opportunity to work with terrific mentors in the space of social determinants of health. I would be remiss if I didn't mention Nick Tim here, who's been on this series previously, I believe, as well as other colleagues nationwide, to really start to incorporate more thoroughly social determinants of health in our perspective. We've actually recently done some work showing that in terms of brain health after stroke, especially after hemorrhagic stroke, there is a clear interaction between social determinants of health, in this case specifically community level socioeconomic status, and the history, the individual's history of success in controlling blood pressure. So it's we're very much on the path to creating that sort of like integrated framework where we really, once again, don't really try to study biological or social determinants of brain health, but really biological and social determinants of brain health. We've been pioneering some attempts at automating the capture of some of this data, using publicly available data, using sort of like dedicated interviews. Some of these social determinants of health are slightly more difficult to study in a stroke survivor, for example. So there's a couple of tweaks.
I'm going to cut you off again just because there's so many juicy questions.
Yeah. Go for it.
So here, this one is sort of a real a key pitch for what we have to do differently. So I'll read the question actually directly. How do you conceptualize brain health differently from heart health? I wonder how much needs to be more about cross collaborations with other disciplines in medicine, including primary care colleagues who are at the forefront of prevention. So
For sure, for sure. I think, we certainly have moved out of an idea of brain health that was very based on the brain as the organ. So sort of like health of things contained inside the skull. And I think we are very eager to move towards more brain health, as in the health of everything that affects brain-related functioning. And certainly heart there are many different axes, I think, to move towards. One is that, of course, broadening the collaboration with different disciplines. It's worth mentioning, I've had the greatest time collaborating with our ophthalmology colleagues in trying to look at how retinal health is probably a part of brain health. And so heart health and kidney health are equally relevant. But I also think it goes back to that barrier between neurology and psychiatry. That barrier is now not a barrier, it's really a communication line. I think we've not necessarily done as good of a job of breaking down the barriers with other disciplines, and primary care is certainly a key collaborator that we want to engage, because whoever wrote the question is right. They're at the forefront.
Well, in fact, and we are. I think, yeah, sorry to interrupt, but I think it's fair to say that we see brain health and brain care as fundamentally the domain of primary care.
And I think it's not a matter of prevention alone, to be fair. It's also a matter of helping those that need restoring brain health. They turn to their primary care. It's their doctor. So I think that's a key next step to move towards. There's no question.
So just again, to keep questions being answered, but just to remind that questioner that in fact there's a whole aspect of the center that is fundamentally engaged with primary care, partnering with primary care. That's really, that's the implementation route.
Right. To which I will confess, I am a novice to implementation. I'm in the process of learning myself, so I'm probably not the best person to.
So this is a question that comes up often, and our patients ask it. Do you see any benefit for the over-the-counter memory enhancements, products and vitamins that seem to be advertised incessantly on the television? And I'll throw in addition, can you add thoughts on any kind of computer games and whether we ought to all be using them?
I'm curious to hear your thoughts after mine, but I'll go first. What I tell my patients is that, there are different approaches to decision making. There is the strictly medical Western medicine defined approach, which is that things have to be proven effective to be effective. And then there are other approaches that are mostly based on things that should not hurt. So what I tell my patient is that we don't have great evidence for all these over-the-counter supplements and their benefit in terms of health, unless they are curing a substantial deficit of a certain vitamin or a certain nutrient. But at the same time, I really value the opportunity of them taking action with something that is, as long as it's something that is safe and that it is part of a partnership. So I don't want to impose necessarily my view, and it's not even my view, but a specific way of viewing brain health care. I really want to have a partnership, and individual patients may feel that after hearing from me, they're not interested, and others really do want to pursue those options in the over-the-counter and nutraceutics and natural remedy space, which I'm very happy to work with on, because I think, once again, the partnership is more important.
I have to cut you off there. We'll have to get to computer games in another conversation because we're out of time. So thanks everyone. And if you have more questions about either Alessandro's lab and the extraordinary work that's going on there, or the center, please check us out on the web. And you can learn more about the Brain Care Score there as well. Thank you very much for joining us.
Thank you all so much.